Hello, my name is Dr. Richard Sawyer and I've been a radiologist in Manchester for more than 30 years. I want to talk about bronchopulmonary aspergillosis and bronchiectasis, and in particular the radiological aspects of this. At the end of this presentation, you should be familiar with the clinical presentation, the classification of ABPA and how radiology can make the diagnosis. There are certain features which make ABPA more likely than bronchiectasis from other causes, and we'll talk a little bit about the optimal radiology technique for follow-up especially, and the slight difference from severe asthma with fungal sensitization. Unlike several of the other varieties of Aspergillus, allergic bronchopulmonary aspergillosis is predominantly due to a reaction of the patient, the host, against the Aspergillus. There's colonization, and then the sensitization causes a very abnormal sort of mucus, which then leads on to the rest of the features. You can't make the diagnosis of ABPA unless the patient has either got asthma or cystic fibrosis. These images are of some of the plugs that are the fundamental problem with ABPA, sometimes called slugs or jelly babies. Patients have often got poor or asthma control with infections. Sometimes they're asymptomatic, but that doesn't mean disease isn't damaging the lung underlying them. On the left is a bronchoscopic image of a plug. If you take a forceps, you'll actually need to exert a moderate amount of force in order to dislodge these plugs. They're very tenacious, very thick. And because they block the bronchus so successfully, secretions build up beyond, and you can see on the right on this pathological specimen the degree of dilatation and filling up of the airway and the consequent consolidation of the lung. Although this looks quite a complicated slide, as a radiologist it's relatively straightforward. You can't diagnose ABPA unless the person's got bronchial asthma or cystic fibrosis, and they should have some features which suggest that there's an IgE, particularly against Aspergillus. Of the last 3 points, the only radiological one is that there need to be some findings which are consistent with ABPA. So although this says mimicking pneumonia, the features are often of bronchiectasis with plugs, and we'll look at several examples of this in due course. The chest radiology is due to this plugging. Essentially, if you block a bronchus, you'll then get changes distal to that. Sometimes just infiltrates close to the hilum, sometimes complete consolidation, sometimes collapse. But the most characteristic feature, and if you see this you can be reasonably sure that it's bronchiectasis, is if you get a gloved finger. On a CT scan this may look like a rabbit's ears, and this is due to the secretions building up in the bronchus, but there's enough collateral air drift around the lung to still leave aerated lung next to the bronchus. If this goes on long enough, you get permanent changes, typically central bronchiectasis, and the more peripheral bronchi appear more normal. On CT you'll see these as ring shadows, and it's much easier to appreciate both the endobronchial plugging and also the bronchiectasis itself. Later on this can lead to pulmonary fibrosis, and there can even be development of other varieties of aspergillosis. On the left is a good example of ABPA with this gloved finger appearance I've mentioned. The fingers are just a bit like a bronchogram, albeit with the bronchi dilated and filled with the secretions. The CT on the right shows this more easily, the division of the bronchus, and again the gross dilatation of the bronchus. You can understand why, when a bronchus has sat like that for some time, perhaps weeks, there's irreversible damage to the bronchus and it never returns to normal. This is a patient with cystic fibrosis who's got an exacerbation of ABPA. In this case, the background X-ray shows mild bronchiectasis. You can see particularly in the right upper zone and at the left apex, but this is normal for this patient. When there's an exacerbation, there's a right mid-zone opacity with an area of consolidation, and the Aspergillus IgE was very abnormal. This is a patient with asthma, and it is a good example of the degree of collapse you can get because of the plugging. Not surprisingly, if your right upper lobe bronchus gets occluded with a plug and no air can get into this area of lung, the lobe will collapse, the fissure will go upwards, and you can see here the fissure is about 50 degrees to the horizontal. In the final right-hand image, the bronchus has become patent again, the plug has dissipated or been removed, but the lung is permanently damaged, and that is now the fissure at about 70 degrees to the horizontal. That lung is, for all intents and purposes, dead and non-functional. We've looked at an example of the central bronchiectasis and these rabbit ears. Sometimes you will see peripheral bronchiectasis, but it's not as characteristic. And one of the most helpful features you see on a CT scan is high attenuation mucus. I'll show that in more detail on the next slide. Sometimes you'll just get migratory opacities where plugs which are less tenacious obstruct an airway, cause problems and then dissipate. And as I've said, the long-term inflammation can lead to this irreversible bronchial dilatation and fibrosis. Just sometimes, because it can be an intermittent allergic process, you may have ABPA, but you haven't got any CT findings, and you're then more reliant on the other two serological causes that I mentioned on the previous slide. It's not characteristic to have a pleural effusion, though sometimes you'll see a bit of fluid, and almost never will you find lymphadenopathy. I'm not going to dwell on the treatment, but in fundamental it's steroids and antifungal agents, and the doctors will have to be very careful because many of the antifungals will potentiate the effect of steroids by altering the metabolism. High attenuation mucus, then I said I would show. On a CT scan, this is recognised when the mucus plug, the material of that is actually denser than that of normal skeletal muscle. And this means that you must look at the images on a mediastinal setting. Essentially, for all intents and purposes, if you see high attenuation mucus, you've got ABPA. There's a very similar process which happens in the sinuses, and again, if you see hyper-attenuating pus gunge inside the sinuses, then you've almost certainly got allergic fungal sinusitis. It's partly due to desiccation, but also iron, manganese, calcium within the mucus causing this increased attenuation. And it's a poor prognostic sign that you are likely to have a higher IgE, more frequent relapses and more need for steroids to control the underlying ABPA. Here's a good example why you need the mediastinal windows. On the left you can see areas of plugging, you've got a small area of bronchiectasis, but on the right you can see the greyness of the mucus is lighter than that of the intercostal or paraspinal muscles. Here's an even more marked example where the high attenuation mucus is almost white, way more dense than that of muscle. Widespread bronchiectasis, you can see that in previous episodes, particularly in the middle lobe on this scan. Another example, also with chronically collapsed areas of lung and a very large area, grossly dilated bronchus with high attenuation mucus within in the right lower lobe. Two more patients showing, in the left-hand image, bilateral lower lobe high attenuation mucus, and on the right-hand image in the middle lobe. Sometimes when you've got the collapse, as I said, it's long-standing. The patient may partly compensate for this, but this patient is likely to have a very poor respiratory tolerance. They've lost the whole of their lung. Their left lung is completely collapsed. It's shrunken. The mediastinum and the heart have moved across to the left. You can see that and probably deduce it even on the chest x-ray. But the high attenuation in the bronchus, inside this mucus, makes the diagnosis. We'll look briefly at some complications of ABPA. Bronchiectasis is almost a permanent part of ABPA, although I've mentioned that it can be intermittent and milder, but it's more common to have bronchiectasis, and each time you get an episode of mucus impaction, that gets worse. Because of the degree of inflammation within the airways, this can result in fixed airway obstruction, and then following on from that you get recurrent bacterial infections, even if you haven't got another attack of ABPA, just because of the underlying bronchiectasis, poor mucus clearance. The allergic reaction to the Aspergillus can then lead on to a more traditional growth of Aspergillus in the lung, so chronic pulmonary aspergillosis, which can be seen with the pleuropulmonary fibrosis and progressive destruction of the lung. That requires a different approach. The treatment with steroids can also result in Addison's disease, as well as diabetes, hypertension, and the other steroid reactions that are commonly seen. And at the end of the day, the person may have severe cor pulmonale with type 2 respiratory failure. If you've got the diagnosis of ABPA, whether the cylindrical bronchiectasis, varicose with irregular bronchi, or areas of sacculation, it really doesn't matter very much, but it's commoner to have the cylindrical and varicose bronchiectasis. Here's some other examples of bronchiectasis. You can see here the bronchus is both dilated and also thick-walled, very typical feature of the inflammation. On the right, you can see, and we'll show it again on the next slide, how the bronchus is bigger than the adjacent pulmonary artery. You can fit the white bit of the artery inside the black circle of the bronchus. This is what I mean by the signet ring sign, common phrase for this, and you can see in the top right image the small white area of the pulmonary artery would fit within the black circle of the bronchus. Clearly, if there was mucus within the bronchus, it would be that you couldn't fit the artery within the area of the high attenuation mucus, but it's the same principle. This is an example where rather than just having parallel dilatation of the bronchi, you've got a very irregular, more varicose vein-like appearance of the bronchiectasis. Again, ABPA. Here's another patient with asthma and ABPA, and perhaps a better example of this beaded appearance of varicose bronchiectasis. More extreme examples, such as the ones with high attenuation mucus I showed before, can have frank saccular or cystic bronchiectasis, and this is just an end stage. If the mucus plug stays in place, secretions carry on building up in the metabolically active lung, which just isn't aerated, and the bronchi get bigger and bigger. Sometimes the degree of inflammation within the wall, the actual plugging isn't the major feature, but sometimes just the inflammation in the wall is very striking. And here you can appreciate the bronchial wall is several times normal. It should be hardly possible to see the bronchial wall. You can't really appreciate it other than just the merest white in the left lung, but on the right it's grossly thickened. Sometimes the coronal images can be helpful, and here you can see in this patient with cystic fibrosis that as well as the dilatation of the bronchi, you've also got gross, widespread bronchial wall thickening. There's less mucus plugging here, and in somebody with cystic fibrosis, this can be secondary to either the cystic fibrosis or the ABPA. I mentioned before that the ABPA can lead on to other forms of aspergillosis where the aspergillus is growing within the lung, and this is an example of a patient with chronic cavitary aspergillosis. You can see that there are dilated, thick-walled bronchi, particularly down in the lower lobes. There's this tram-line appearance. That's a non-specific feature of bronchiectasis. That doesn't mean you've got ABPA. This is another example showing a patient who's transitioned from ABPA, baseline image on the left chest x-ray, and then on the right you can see much more widespread, more fibrosis, and this is a patient with chronic cavitary pulmonary aspergillosis. The CT scan shows the underlying features, areas classically with more pleural change, areas of dense fibrosis, rather than just the pure plugging and areas of consolidation and collapse that we've seen with ABPA. Here's a classification of ABPA which you may find useful. essentially it's looking at the whole spectrum from asymptomatic, acute presentations, people who are relapsing, who might then go into remission, people who are treatment dependent, possibly people who are steroid dependent, and then the very advanced changes. It's a very logical progression. The clinicians may find this useful. It's not predominantly radiological, however. I said we'd talk briefly about SAFs, which is a patient with severe asthma who has a sensitivity to fungi, but they don't actually develop the plugging. So if you see plugging, you haven't got severe asthma with fungal sensitization, but you still have got the bronchial wall thickening and a minor degree of bronchiectasis. So I think there are helpful features. If you see somebody with high attenuation mucus, it's ABPA. If you see somebody with quite extensive dilatation and extensive plugging, then it's likely to be ABPA. But if you've got sensitivity shown on the serology and you've got severe asthma, but you haven't got such widespread bronchiectasis, then it's likely to be SAFs. So ABPA is predominantly the patient reacting badly to the Aspergillus. They have to have asthma or cystic fibrosis. Usually the patient will be atopic, though occasionally you can get a hypersensitivity pneumonitis in somebody who hasn't got an atopic feature. And it's probable that both ABPA and SAFs are significantly underdiagnosed, and we as radiologists can be very helpful in at least suggesting this possibility. Thank you very much.